Right, just making sure everybody can see the screen. And I thought what we would do is the didactic is on orally available drugs or antibiotics, highly available oral antibiotics. I thought we would do a teaching exercise we've done here at WVU a few times before. We are doing a trial called COPAT, which stands for Comparing Oral versus Parenteral Antimicrobial Therapy. So on the inpatient setting, any patient being seen that needs more than 2 weeks of IV antibiotics has the opportunity to be randomized 2-to-1 to either an oral regimen or an IV regimen if appropriate. Again, depending that we have good oral or IV options for these patients. As most of you know, there is very good data for endovascular infections and for bone and joint infections that earlier transition from IV to oral antibiotics works just as well. So we wanted to extend this to beyond bone and joint and endovascular infections and to even earlier than the trials, which had looked at transitioning at about 7 days to 10 days. So this is a compilation of 15 cases that actually participated in the clinical trial. Strongly encourage you to please participate in this Jeopardy. If you could scan the QR code.
For us.
Okay. So if you could please scan in the QR code, it will take you to a website which just asks for some very basic information. Make sure it's working. Yeah, thank you. And once you fill out the information, go on, submit it, and move on to the next page. And that will bring you to the answer sheet where we are going to answer the questions about these 15 patients. So the patients are divided into 5 categories. And the inspiration for the titles comes from Taylor Swift. Bad blood are 3 cases of endovascular infections. Death by 1,000 cuts are 3 cases of diabetic foot infections. Breathe are pulmonary infections. Castles crumbling are bone and joint infections. And blank space are 3 cases that are miscellaneous and couldn't fit in the other 4 categories. And the format is pretty simple. I will give you a first slide with information on the patient at the time of randomization. And for each of these cases, the question is the same. What is your comfort level transitioning this patient at this time from an intravenous regimen to an oral regimen? That's the gist of the question for all these cases. All right, so we'll go ahead and get started with our first patient. And again, these are actual cases that were enrolled in the trial. 57-year-old male, admitted in August for shortness of breath and extreme fatigue that had been going on for a couple of months. His past medical history is significant for aortic stenosis. Blood cultures are positive for a viridans group strep. The penicillin MIC is in the intermediate range. Remember, less than 0.1 is the very sensitive range. A TEE confirmed that there was a hypomobile mass, confirming the diagnosis of infective endocarditis. There was severe stenosis and regurg. Patient underwent mechanical valve replacement on August 25th. So you can see within 6 days of his hospitalization, the operative gram stain is positive, but the cultures are negative, which is not uncommon for a lot of strep infections when the surgery is done within the first week. The antibiotics he was on had sterilized the sample. Pathology is consistent with infective endocarditis, and the patient is currently on ceftriaxone. Question: What is your current comfort level transitioning this patient from IV ceftriaxone to an oral regimen? I'll give you a few seconds here to answer the question on that website. And we'll move on to the answer of what happened to the patient. So this patient was randomized to the oral arm and treated with levofloxacin 750 milligram daily. Levoquin at that dose gives me a peak serum concentration of 15. The patient's MIC to quinolones was 0.5. So I have a more than 10-fold difference, and that's usually indicative of cures. And we treated the patient for 4 weeks rather than 6 weeks because the intraoperative cultures were negative. The patient was evaluated at the end of the trial, which is a 3-month visit, and he was doing very well, walking around and had no chest discomfort. So essentially, our first case is a 57-year-old with aortic stenosis with streptococcal native bicuspid aortic valve endocarditis, who undergoes source control, has negative intraoperative cultures, who completes 4 weeks of oral antibiotics and was doing well 2 months off his antibiotics. Maximum CRP, latest CRP. And you will see that in some cases, we've used the CRP to extend therapy if needed. So that's your first case, and the others are going to follow a very similar format. We are testing comfort levels. Next case for endovascular is a 71-year-old male. He was admitted in September for MSSA bacteremia. His blood cultures cleared pretty quickly. By the 20th, he was negative. And we thought this came from a skin and soft tissue focus. He did have a past history of very significant grafts with an aortic abdominal aneurysm with an open repair in 2015, an arch dissection with a replacement with prosthetic material in 2017. During his evaluation, the CT imaging raised some concerns for aortitis, but this was thought less likely by the consulting services given the quick clearance of the bacteremia and the other evaluations by CT surgery. At the time of randomization, he's on IV cefazolin. So MSSA bacteremia, previous vascular grafts on IV cefazolin. What is your current comfort level transitioning this patient from IV to PO? Go ahead and fill your response. This patient was randomized to the oral arm and treated with cefadroxil. So cefadroxil has really good oral bioavailability. It's a first-generation cephalosporin at the dose of 1 gram BID. It has really high levels and very well tolerated. He too was treated for 4 weeks and did quite well. So this is essentially a 71-year-old male, heart disease, peripheral arterial disease, with an arch replacement, recent quick resolving MSSA bacteremia from a skin soft tissue focus, who completed 4 weeks of cefadroxil and is back to baseline off antibiotics at the 3-month evaluation. Maximum CRP, most recent CRP. Last case under endovascular infections is a young man who has a history of an ascending aortic aneurysm, admitted in October for fever, aches for the past 2 months. So a subacute presentation. Blood cultures grow a virulent strep, very sensitive to penicillin. So this is one of those super sensitive streps. It cleared quickly on the 20th. The TEE showed subaortic vegetation, a bicuspid aortic valve with severe regurgitation, and mildly reduced ejection fraction, in addition to his severely dilated aortic root. Patient undergoes aortic valve repair, as well as a primary repair of the cusp and replacement of the ascending aorta, so prosthetic material. His intraoperative cultures are positive with the same organism, the viridans group strep. Patient is on IV ceftriaxone. what is your comfort level or current comfort level treating this kind of patient with oral antibiotics? This patient was randomized to the oral arm 72 hours after his surgery, and we gave him high dose amoxicillin, 1 gram 3 times a day. The serum levels are 10 to 15, and remember that his amoxicillin MIC is less than 0.25. So again, easily getting the 10-fold higher threshold that we aim for. Because his intraoperative cultures were positive, he got 6 weeks of treatment. Did very, very well. When we saw him at the 3-month visit, he was clinically doing very well. His CRP had normalized to 4. So again, a 33-year-old male with strep, native bicuspid aortic valve endocarditis, undergoes source control and treated with oral antimicrobials for 6 weeks and did well. Any questions on the endovascular cases? All right, I'll keep going. Diabetic foot infections or death by 1,000 cuts, just a reminder that these are the patients that tend to need multiple surgeries. So our first patient is a 51-year-old diabetic with poor control, has neuropathy, admitted in October with a right diabetic foot polymicrobial infection, undergoes and has post-osteomyelitis as well as metatarsophalangeal joint, septic arthritis, and osteomyelitis. He has had exposure to outpatient antimicrobials. Blood cultures were negative. MRSA screen is negative. Patient undergoes pretty definitive surgery, right foot IND, partial first ray amputation at the level that is proximal to the first MTP joint. Podiatry expressed concern for residual infection and osteomyelitis. My operative aerobic cultures have MSSA and Enterococcus. Patient was on IV bank, cefepime, and metronidazole. What's your comfort level? This is very similar case to the one Jacobs presented. What's your comfort level transitioning this patient from IV to oral antibiotics? Patients randomized to the experimental or oral antibiotic arm, we transition the patient to Levaquin and Augmentin to complete 4 to 6 weeks. The range is given based on CRP normalization. CRP was not normal at 4 weeks, so therapy is continued for 6 weeks post-operatively. So essentially a diabetic foot polymicrobial infection, status post-surgical control, but with some concern for residual infection, treated with oral antimicrobials, maximum CRP 163, most recent one was about 11. This patient's evaluation is at 3 months' time. These are the patients that, it takes 6 months, 1 year to see exactly how well they do. All right, next case for diabetic foot infection has a picture to go with it. 68-year-old male, diabetic, hospitalized in August with an infected right diabetic Charcot foot. And you can see the patient's lost the arch of the foot and has this redness and swelling in the midfoot. Patient was also bacteremic with MRSA, and bacteremia cleared by the 24th. He's admitted on the 22nd. IND is done a day later on the 25th. Operative cultures grow MRSA, so monomicrobial process. Pathology shows acute osteomyelitis and osteonecrosis, as you would expect with a Charcot foot. So what's your current foot level with a Charcot foot with MRSA bacteremia, transitioning from IV to oral antimicrobials? This patient's randomized to the oral arm, transitioned from bank to linezolid for a total of 6 weeks, followed by doxycycline oral suppression for 3 months. Why would we do that? Charcot foots are usually neuropathic feet, and there is poor vascularity. And in some minds, that's not different than, dead bone that still has bugs attached to it. So it's not uncommon for some of us to use a kind of prosthesis infection approach for some of these patients. So essentially, this is a 68-year-old male infected right diabetic Charcot foot with MRSA bacteremia, undergoes IND, doing very well at the 3-month mark. Maximum CRP, latest CRP, you can see it's not normalized, but the foot looks really, really good. Now, unfortunately, what I'm not showing you is the other foot. And this patient had developed an infection of the other foot and was undergoing problems with the other foot. And this is probably where some of this elevated CRP was coming from. But it's a reminder that it's not just, one episode with diabetic foot infections. You tend to deal with them over and over again. All right, last case for diabetic foot infection. 46-year-old male, poorly controlled diabetic, admitted in September towards the end for MRSA bacteremia. We had positive cultures on the 26th and 28th of September, negative cultures on the 30th. Also had bacteriuria with a positive culture on the 25th. And the assumption was this was a descending bacteriuria. In other words, an MRSA bacteremia with bacteriuria. The source was felt to be this diabetic foot infected callus. Doesn't look very dramatic, but that's what was felt to be the source at that time. Patient is on IV antibiotics for his MRSA bacteremia. What is your comfort level transitioning this patient from IV to PO? Patients randomized to the experimental arm, started on linezolid for 4 weeks. He's seen at the 6-week visit on November the 15th. The foot wound has healed. Pictures are recorded in his chart. He's doing very well. At the 3-month mark, as far as his diabetic foot infection with MRSA bacteremia goes, this was thought to be a clinical cure with the 4 weeks of oral linezolid. Normalized CRP. What we found out later at the 3-month mark on this patient was that his dysuria symptoms recurred and a repeat urine culture was again positive for MRSA. And in retrospect, what he probably had all along was an MRSA prostatitis. And he was subsequently treated with a 3-month course of appropriate therapy and did quite well. All right, let's move on to pulmonary infections. 75-year-old male with diabetes, reasonably well controlled, admitted in July after a 20-foot fall from a ladder, resulting in left rib fractures and hemothorax that caused an empyema and trapped lung. Blood cultures grew MRSA, clearance by July 31st. An IR drain of the left pleural fluid confirmed the empyema. It grew MRSA. Patient undergoes definitive source control with a left chest wound exploration, thoracotomy with decortification, and a chest tube placement on August the 4th. Operative cultures also grow MRSA. So we have a MRSA pulmonary process with source control. Comfort level transitioning this patient from IV to PO antibiotics. This patient's randomized to the oral arm, transitions from vancomycin to linezolid. The plan is for 4 to 6 weeks. Labs on the 5th at this 4-week mark show the CRP is still elevated, so we continue linezolid for a full 6 weeks. At the 12-week evaluation, patient's doing very well clinically. He's off his antibiotics, and CRP is near normal, and the chest imaging is normal. So an MRSA empyema treated with oral antibiotics after source control. All right, pulmonary second case is probably the most complicated patient we had in the clinical trial. Significant past history, elderly gentleman, 72-year-old, ampullary adenocarcinoma, which was treated with a Whipple's in March 23. He did have mets to the liver, for which he underwent resection in May 23, developed a polymicrobial left perihepatic abscess with Klebsiella and enterococcal bacteremia. This is all his past history. He underwent an IR drain placement and at that time was treated with AMP, ceftriaxone, and flagyl for a 4-week course until June 29. His current hospitalization was on July the 30th till August the 22nd, so a long hospital stay, when he presented with a hepatic abscess extending through the diaphragm to form a right empyema. So you can see this is where he had his liver problem, and it was extending into the pulmonary cavity across the diaphragm. Patient undergoes a chest tube as well as a hepatic drain placement, and the cultures are positive for Enterococcus, Lactobacillus, Klebsiella, and Citrobacter. You will identify the Kleb and the Enterococcus were there previously in his previous problems as well. He undergoes definitive source control with a right-sided VATS with decortication on August the 1st. At the time of his randomization, patient is on linezolid, cefepime, and metronidazole. What is your current comfort level transitioning this complicated patient from IV to oral antibiotics, again, for predominantly a pulmonary process, which is an extension of a pyogenic liver abscess with source control? Patients randomized to the oral arm, regimens changed to Levaquin and Augmentin to complete 4 weeks postoperatively. Given the adequacy of the source control, we thought 4 weeks would be more than adequate. Again, using CRP normalization, patient does very well. At the 12-week mark, he's a couple of months off his antimicrobial therapy, CRP is normalized, and his imaging is better as well. Maximum CRP 306, latest 4.2. All right. Last case under pulmonary is a young man, 22-year-old, prior heart murmur, recently diagnosed diabetic, admitted in August with MSSA bacteremia. He presented with fever, weakness, and body aches. Blood cultures grew MSSA, cleared on August the 6th. So you can see it did take a slightly longer time for blood cultures to clear. CT is consistent with septic pulmonary emboli. The transesophageal echo shows a VSD, which did not have a vegetation on it at the time of evaluation. Adult congenital cardiology saw the patient and recommended a VSD surgical closure on an elective basis. At the time of evaluation, patient is receiving IV cefazolin. The ID team's consensus diagnosis was this is most likely a VSD, infective endocarditis with MSSA with septic PE. And as you know, VSD endocarditis embolizes to the lungs and behaves like a right-sided endocarditis. What's your comfort level transitioning this young man from cefazolin to an oral antimicrobial for his MSSA endocarditis? Patients randomized to the oral arm treated with cefadroxil, 1 gram twice a day for 6 weeks. After completing his antibiotics, a month later, he undergoes an elective readmission for his VSD surgical closure, and this was a short hospital stay, 3 days, and he's out. At his 12-week completion of trial, he's doing very well. So essentially a 22-year-old MSSA VSD endocarditis presenting as a septic PE who is treated with 6 weeks of oral antibiotics, undergoes elective VSD surgical repair, back to his normal self. Maximum CRP and latest CRP. All right, let's move on to Castle's crumbling or bone and joint infections. The first one is a 34-year-old female who had some chronic posterior skin ulcerative changes from lichen simplex, who is admitted in September with left sacroiliac septic arthritis and iliopsoas for pyomyositis. So that's what a normal sacroiliac joint should look like. and that was her left sacroiliac joint. You can see that this has been a chronic process with erosion of the bone, with inflammatory changes of the iliopsoas muscle. She undergoes a CT-guided biopsy, and that grows MRSA. Her blood cultures are negative. So we don't have bacteremia, but we have clear evidence of a bone and joint infection with MRSA. What's your comfort level transitioning this patient from IV antibiotics to PO? This patient's randomized to linezolid, planned for 4 to 6 weeks. She has a decrease in her platelet count noted on the labs on September the 25th, which was just 5 days before a scheduled 4-week end date. Linezolid was transitioned to doxycycline for a couple more weeks, and we completed out a 6-week course. Did very well at the 12-week evaluation, essentially sacroiliac septic arthritis, iliopsoas pyomyositis, no surgical control, treated with oral antimicrobial regimen, CRP normalization or near normal at the time of final evaluation. Next patient, 43-year-old diabetic, poorly controlled, has had a prior hand fracture for which he has a plate and screw, who is admitted in November with a right hand hardware-associated MRSA infection. Blood cultures are negative. The CT confirms that this is infected hardware. He undergoes surgical treatment with removal of the infected hardware, and your intraoperative cultures grow MRSA. He's on vancomycin and ampicillin sulbactam. Comfort level transitioning this patient from IV to orals. Patients transition to linezolid, 4 to 6 weeks postoperatively, and he did quite well again with CRP normalization. He did the 4 weeks because his CRP normalized quite early. Essentially, hardware-associated MRSA infection treated with surgical control and hardware removal, which I think makes us a lot more comfortable that we have good source control. All right, last patient under bone and joints is a prosthetic joint infection. Patient who was 71-year-old, followed in our MSK musculoskeletal joint ID clinic for a left prosthetic hip infection. His original hip arthroplasty was in Ohio in March 22. He established care with us in 2023 and aspirate in October screw Enterobacter cloacae. So pretty confirmed diagnosis of a prosthetic joint infection. Patient underwent resection arthroplasty, followed by insertion of an articulating antibiotic spacer, and the operative cultures grew the same Enterobacter cloacae complex. So for a prosthetic joint infection with a resection arthroplasty and an articulating antibiotic spacer, what's your comfort level treating his Enterobacter cloacae with an oral antimicrobial? This patient's randomized to the oral arm and treated with Levaquin. We used the higher dose, 750 milligrams daily for 6 weeks. End date was November 27, 2023. So essentially a prosthetic joint Enterobacter infection treated with a resection arthroplasty. Patient doing very well. CRP near normalized. Some of these patients can be transitioned to continued doxycycline suppression, and I think a lot of that decision is based on comfort level with chronic doxy suppression and source control assessments with the surgeon. All right, the last 3 cases are miscellaneous cases. And this one's a hepatic abscess, 74-year-old female. She was transferred to this institution with acute cholecystitis with a hepatic abscess. You can see a very clearly defined thick-rimmed abscess. An aspirate of this grew a Citrobacter. What's your comfort level treating a Citrobacter hepatic abscess of a biliary focus with oral antibiotics? Patient was treated or randomized to the oral arm and treated with Levaquin and Flagyl, completed 6 weeks following her drainage procedure, and the repeat CT showed complete resolution, had the drainage catheter removed, and subsequently plans were underway for a cholecystectomy. So essentially a pyogenic liver abscess that has been drained with the cholecystostomy tube and an IR drainage catheter treated with oral antimicrobials with CRP normalization. Couple more cases. 63-year-old diabetic patient admitted in August with MSSA, left iliopsoas pyomyositis, and perinephric abscess with bacteremia. So you can see this is the normal kidney on the right. The left-sided kidney has this inflammatory process in the inferior pole and affecting the iliopsoas muscle. And blood cultures are growing MSSA. She undergoes a CT-guided perinephric abscess drainage with the catheter placement for source control on the 18th. MSSA bacteremia clearance is not till the 23rd. These cultures also grow the MSSA. This drain is subsequently removed on the 14th. So what's your comfort level treating an MSSA, iliopsoas pyomyositis, and perinephric abscess with oral antimicrobials? Patients randomized from IV cefazolin to cefadroxil, and you could ask the question, when should you transition? We chose to transition 48 hours after bacteremia was confirmed to be cleared. Why 48 hours? That's our comfort level. Maybe others might want to do it earlier once the drainage catheter has been placed. The plan was for 4 weeks since we thought there was reasonable source control, and again, guided by the CRP. And this patient, we did have CRP normalization at the 4-week mark. So essentially, iliopsoas pyomyositis, perinephric abscess, secondary to MSSA, treated with an oral agent with clinical improvement as well as resolution on the scans. Last patient, 52-year-old, high BMI, status post-gastric bypass, has bilateral total knee arthroplasties and lumbar stenosis, for which the patient undergoes decompression and fusion with hardware on July 11th. Patients admitted a month later with an MRSA, posterior lumbar wound, superficial as well as deep infection, undergoes surgery with wound revision and wound vac application on the 15th. Operative cultures grow MRSA. Remember, there's hardware in place. She is on vancomycin and rifampin. So for hardware infection with MRSA on vanc and rifampin, what is your comfort level transitioning from IV to an oral regimen? This patient's randomized to the experimental and oral arm and transitioned to linezolid and rifampin with plans for 6 weeks of therapy followed by 6 months of doxysuppression. So essentially, we're treating an MRSA superficial and deep lumbar wound infection with underlying hardware with oral agents. At the 12-week assessment, patients doing well clinically, no assessment, no evidence of persistent or relapsed infection, CRP maximum 8.7, latest 1.0. At this point, the rifampin linezolid is transitioned over to the oral doxycycline, obviously. All right, so those are just examples of some cases, actual cases that were randomized to the oral arm of the trial. And we basically took the first few that could fit in these categories. We now have many more. You have 2 final Jeopardy questions. If you scroll down on your page, the first final Jeopardy question asks you, after reviewing these 15 cases, I feel more comfortable with earlier transition from IV to PO antibiotics. Yes or no? And your second question asks you if you needed prolonged antibiotics and had good oral options, you would still prefer to get a PICC line and start with IV. Start with IV. Again, yes or no. This is just checking preferences. And I think the last thing on your website is if you felt uncomfortable asking for the top 2 reasons why you feel uncomfortable with the IV to oral transition. And I think you have a few options to select from. So would appreciate if you participate and select out any of those responses. I'll stop sharing here and happy to get any feedback or input from anybody else. These are patients directly from the clinical trial.
Would you use patients who have thoracentesis instead of like a total decortication for the pleural effusions or, sorry, crampoedema?
My own preference is if the thoracentesis is with a wide bore chest tube, then yes. The problem is some of the chest tubes that are done by IR get blocked very easily, and I don't feel that's adequate source control. I don't know if others have a different approach.
One thought I had when we were going through the cases is when I was hesitant about a couple of, or just like, do they absorb them? So the gastric bypass patient, you know, a classic Roux-en-Y might have some absorption issues, although I don't know if that was the case in the patient, and then the Whipple. So those two gave me a little bit of pause. Doesn't mean I wouldn't have used oral. It just means I would have been like, let me like read a little bit first to make sure like the gut is working in our favor.
And I think those were probably among the 2 patients where we spent the most time taking time to consent, as in making sure the patients understood all the complexities of, you know, we're not 100% sure, but you're taking your blood pressure medicines as well, and your blood pressure is under control. So the assumption is,
yeah, that's a good indication. Yeah.
I think the 2 themes in the ID world are shorter duration. Definitely, we are starting to, in my own practice, I've realized that the 6-week mark has become the outlier. Most patients, I think, can be treated with shorter courses, especially if you have good source control, which seems to be the highlight. You know, if your source is controlled, then you can talk about maybe 2 to 4 weeks of therapy. And then for certain agents, the oral transition is a lot easier. I mean, obviously, we don't have a good ESBL oral antibiotic yet, but for Staph aureus, for both MRSA, MSSA, there's certainly a comfort level transitioning to oral for most of the infections.
No, I use Bactrim for the ESBL2 sometimes if it's sensitive or sick though.
I think my own bias, again, you know, we get biased with certain drugs we use. I love Bactrim. I've used it a lot for obviously PCP and other indications. I've been a couple of patients with prostatitis and all, hyperkalemia, creatinine elevations. And so it's one of those drugs I really, really am grateful that I have colleagues who are following these labs on patients to make sure that they do well. It probably has more prevalence of some of the toxicities than, say, you know, ceftriaxone or even linezolid, to be honest with you.
from a COPAT monitoring standpoint, in fact, there was one that watched closer for those reasons.